All right, last lecture before your exam. So let's go over pediatric liver disease. Okay, so let's look at neonatal jaundice. He had several slides on this. So there's two really types of jaundice. There's unconjugated and conjugated jaundice. So it's either indirect jaundice or direct. So direct is conjugated, unconjugated is indirect. So, I mean, easy way to remember to know which one is which. Un and in, both mean not. So either it's not direct or it's direct, or it's not conjugated or it's conjugated. So prehepatic forms of jaundice are going to be examples of that would be hemolysis or hemorrhage. And intrahepatic in the liver are going to be like the things that we had talked about before, like Crigler-Najjar syndrome, Dublin-Johnson, Gilbert, Rotor hepatitis, or sepsis. And then posthepatic are going to be things like atresia, sepsis, or obstruction. So I like to start with that. And when I get a question, think, okay, is this a cause like based on direct or indirect? Is it really, I sort of like ask myself a question. Does this have to do with the blood? Like, if it is something that's like pretty much blood related, it's going to be like either hemolysis or hemorrhage or anything else. Then that's prehepatic, and I know it's indirect. If it's posthepatic, and I know it's, if I know it's a liver issue or like near the liver issue, then I'm gonna be like thinking direct and conjugated. And so like that part is done. So unconjugated is going to be lipid soluble. Lipid soluble bilirubin is going to be able to cross the blood-brain barrier, and it can cause kernicterus. Kernicterus is important to know because this is like a level of bilirubin that's going to be building up in the brain and causing encephalopathy, which can lead to death. In the urine, it cannot be excreted. However, with conjugated, it's water soluble, so it's able to be excreted by the kidneys. It doesn't cause kernicterus because it can't cross the blood-brain barrier. Why do we care? So unconjugated forms of jaundice in the neonatal period can be fixed and switched to conjugated by putting the baby under a blue light. So when a baby's born, they check them they check their bilirubin levels. And then as the days approach, if they start turning yellow, they'll check and see where the bilirubin level is and then put them under this light. And you've probably seen it or heard of it before. Physiological jaundice is unconjugated jaundice. It has an onset of the first week of life. The bilirubin slowly starts to increase. It's usually less than 5. And it's a form of like indirect bilirubin that resolves by day 10. Again, remember that you just take the total bilirubin minus direct to give us our indirect. Pathologic is going to be a bilirubin that's much higher. It's going to have an onset of within the first day. And direct bilirubin is going to be elevated. So looking at different causes. So direct bilirubin could be, again, causes like hepatic sepsis or a metabolism issue. And then indirect, we've got some different methods. So we can, we think, okay, it's a blood issue. So let's get a Coombs test or a direct antigen antibody test to see if we have a ABO incompatibility. If we do, then there's our issue. So, or if it's a RH disease, that's also called isoimmunization. Mom has to get checked before she's born or before the baby's born to see if if she's RH positive or RH negative. The problem arises when mom is RH negative and baby is RH positive. So mom starts building antibodies up, and within the first baby, it's not as problematic for mom, but it is problematic as we go along for baby. So mom has to take medicine in order to or ROGAM in order to not cause this incompatibility. The problem with the baby is that they get jaundice. So let's say that the Coombs test is negative or our DAT is negative. Same thing. Then we look at hemoglobin. Okay. Was the baby a twin? Was there delayed cord clamping, which it's a common practice? Like, do we have like some reason that baby had to get like a blood transfusion or something like that? If they have a high hemoglobin, then maybe it was due to a transfusion or like getting too much blood. If it's normal, then we look at the reticulocytes. So then we think, okay, well, maybe it's one of those heme blood disorders that we learned about, like spherocytosis, G6PD deficiency, or pyruvate kinase deficiency causing hemolysis. Or maybe there's a hemorrhage causing a bleed. If there are reticulocytes, which just like to remember, show like red blood cell turnover, if they are not increased, we don't have a lot of turnover, then maybe it's in a reabsorption issue, like hemorrhage or breastfeeding or breast milk jaundice. So this is complicated, but taking it step by step can help you know the different causes of neonatal jaundice. So looking at reabsorption jaundice, there's breastfeeding jaundice and breast milk jaundice. So these are really confusing sometimes. So breastfeeding jaundice is a feeding problem. They don't eat enough. Breast milk jaundice is a milk problem. The milk is not good enough quality that instead they aren't getting like the bilirubin they need. Breastfeeding, they're not able to like move their bowels enough to be able to like to create the body to conjugate the bilirubin. So there's not enough gut motility with breastfeeding. It's a greater reabsorption, and it's the unconjugated form again. So basically just feed baby more. So either more breastfeeding, or you can like supplement with formula as well. Breast milk jaundice is that mom lacks the enzymes 2,3-UDPGT in order to be able to produce good milk. So there's less conjugation, and so we have an increased unconjugated form. So instead of supplementing with formula, we're going to replace mom's milk instead. We're going to give formula. So if the milk's not good, give formula. If they're not eating enough, then you supplement with formula. Biliary atresia is, again, like it's a cholestasis, impaired bowel formation and bowel flow. So we have defects in hepatocyte bile secretion, and so they get jaundice and pruritus. Again, like they have an elevated GGT. And so there's going to be plugs in the dilated bile caniculi that are ingested by Kupffer cells. So the treatment is going to be surgery, where they connect the stomach and the intestines with the liver. So basically we've got this, we've got our normal pathology where our bile goes into the duodenum. So instead, we're going to kind of bypass the ducts and go like straight to the liver where the bile is made. But it's really not important. Or some of this, if it's not treated enough, like early enough, then they may have to have a liver transplant. Allergies syndrome, he had a star by this. I would know that it's autosomal dominant and it's a JAG1 mutation. Symptoms are going to be jaundice, pruritus, pale stools, and poor weight gain, poor growth, and then lipid soluble vitamin deficiency. So like ADEK. Okay. That is it. So good luck on your exam.